All right. So, perfect. So what I'm going to do is we're going to first look over the Socrative quiz that I had posted for you guys. So these are the answers to these. I'm going to walk through them real quick. It didn't look like that many people attempted it, and it may have just been because of the timing of posting it, or maybe other things ran through and they just got busy, which is fine. I'm going to leave it up until, of course, when I post the next one, which will probably be on Saturday. I'll probably post it because Friday I got the test, and then I'll probably work on it on Saturday. So I'll probably post it on Saturday, the new Socrative quiz. But with that being said, let's look through these guys. So here on this first question, it's essentially just asking you like most likely key players in maintaining the population of these abnormal cells. So we have these abnormal cells, and for some reason they're not dying, right? So they're asking, why is that? It's because these cells that are abnormal, they're producing a lot of anti-apoptotic proteins. And the reason why I'm saying that is this, because when you have a cell with its DNA, and in the DNA, you're doing massive amount of changes to the DNA because of how rapidly these cells are dividing, P53 gets activated, right? As well as other factors, right? Now, what these guys end up doing, right, is they end up stopping the replication process, ends up stopping this so ATM can come through, scan through the DNA, fix the issues. You can have base excision repair undergoing, and that can do its stuff. Anyways, all this stuff undergoes, and if you can't fix it, then you undergo apoptosis. Right? Now, if you cannot undergo apoptosis because you have all these high anti-apoptotic factors, then apoptosis will not occur, and you'll just have these abnormal cells present. And that's essentially what's going on here. Okay, hold on one second, guys. Someone else wants to add in to this, and I need to send them a link. Oh, this last session. Okay, hold on one second. Let me pause. Okay, sorry about that. All right, so let's continue. So that's how this breaks down with this first one. P53 isn't the answer here because once again, P53 deals with stopping of division, stopping of the S phase, not so much stopping the cells from not dying, right? So that's why P53 isn't the right answer. And then FAS and perforin, these are the guys that deal with CD8 cells and it being pro-apoptosis, right? They cause them to die. And then BAX is also along that same category and pathway. All right, good. Now, here with this next question, we have this African American, which is very important because when we read down more, you read that this person has a growth that's hard and rubbery, exhibits no fluctuations or tenderness. So this is essentially explaining or describing to you what is known as a keloid. Okay, and once again, keloids are in African Americans more prominently. They're in locations like the earlobes, the face, the chin, all these type of areas, right? Is where you see these keloids being present. Now, if you were to do a biopsy of the keloid, you would see excessive collagen synthesis, yes, but which type of collagen would you see? You would see type 1. as well as type 3. Perfect. How is this different with a hypertrophic scar? So keloids are the ones that are outside of the borders. They're the ones that are very haphazard. They extend too far outside the border. Hypertrophic scar is the one that is inside the borders, and I'll show you a picture of it, and is only type 3. Okay. Yeah, great. Okay, so these other guys we'll walk through. So dermal contracture, no, that's not what this is, because dermal contracture, right, is when you get tight skin that then prevents you from doing functions like grabbing onto things. Usually happens after burns, right, when I was explaining, and is due to what cell? What is the cell? Yes, myofibroblast. Perfect. Perfect, perfect, perfect. Now, my next question is, these myofibroblasts, what is stimulating them to become them? What is stimulating myofibroblasts to develop?
So when you say what's stimulating them, I don't
Yeah, like
know.
there's something
My,
that goes to these guys that stimulates them to become myofibroblasts. Because
it sure
originally they're just
is,
fibroblasts,
right?
but something comes to hit them, and then all of a sudden they become myofibroblasts.
It's not MMP, is it?
No, insulin growth factor beta. Okay. And I'll show you in the picture down here because I have it brought down. Oh, no, it's in the actual lecture thing. Here we go. I'll show you here. Here it is. IGF beta stimulates these guys to become myofibroblasts, and they undergo all the factors of stuff that we're talking about. Okay? They not only stimulate fibroblasts to do angiogenesis and that stuff, but also with these myofibroblasts. This IGF beta. Okay? Good. Good, good, good. All right. Now, let's continue. So, let's see here. If you had a persistent infection, what does that lead to? Persistent
It's a
infection.
it's a delay in wound healing.
Yes, a delay in wound healing. I do agree. What else? We talked about something very particular that you see when you get persistent infections.
Granuloma.
Yes, good. So in persistent infections, you usually end up getting granulomas. Good, 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 good. What type of granuloma?
That's the chronic one, right?
Because you got caseating ones and non-caseating.
The one that's non-necrosis.
So if you get an infection, you got to think these are bacteria. when we went over the aspect of granulomas, we talked about how bacteria, they produce a lot of cell killing factors, right? They kill off cells. So if you have a cell that's eaten this parasite, eventually the cell will die, right? So when the cell dies, it ends up being necrotic in the center, which is what caseating is. The factors that do not kill, things like fibers, pieces of strands of tissue, such as asbestosis and stuff like that, they cause more non-caseating. Okay, silicosis is another one with silica, right? That's not a bacteria. It's literally just a foreign material that's not really dangerous. It just causes chronic inflammation, right? Which leads to granulomas. All right, chronic inflammation, granulomas, caseating or non-caseating, depending on if it's bacterial or not. Okay, good. Now, wound remodeling. If this was wound remodeling, what would have been happening to the collagen? Yes, good. It would have been changed from type 3 to type 1, right? And what is the guy that's responsible for changing type 3 into type 1? Yes, MMP. Perfect with that zinc. Okay. Good. Okay. So for this one's a little bit more difficult because I didn't really talk too much on cachexia, cancer cachexia, because we're going to talk about that when we do neoplasms or neoplasias. But this was a good segue with pathology and a little bit of neoplasia as well. So what's essentially going on here is when you get cancer cachexia, you got to think of it as chronic inflammation. Chronic inflammation, right? Because cancer cells are always there. They're always, invading in the tissues. They're breaking down basement membranes. They're moving about throughout the body. Okay. So, with that being said, you always have to then think that, oh, we have some kind of interleukins being present. When you have chronic inflammation, you get things like IL-1, IL-6, IL-8, IL-12, and then TNF alpha. Now, when you have these factors chronically, what they end up doing is they start to augment your cell's metabolism. Okay? To the point that your cells will start to break down fat and proteins much quicker. And that is what leads to individuals who get cancer, why they lose weight, why they look thin, why they look frail, because they're breaking down massive amounts of protein. They're breaking down massive amounts of fat. Why? Because these factors here stimulate those cells to increase that stuff. And then where do you think this protein and fat is going to? Straight to the cancer. And it feeds off of it. So that's how this ends up working. The cancer ends up getting more nutrients by using this chronic inflammation that is causing your body to break down more protein and fat that your cancer is then soaking up and utilizing, okay, to help it grow faster. And that's essentially how you get this cancer cachexia. All right. So really think of this as an increase in basal metabolic rate. Okay. That's the biggie. Not so much atrophy of due to decreased blood supply. It's more of you burn off more. All right, good. So with that being said, it ends up being this one here, because those are your factors. TNF alpha, IL-6 is another big one that does it. IL-8, IL-1, these are the big guys. Now, tumor nutritional demands is not it, because yeah, the cancer does get it, which is why they threw that in here as an answer choice. Yeah, the cancer does, absorb the nutrients, but that's not why the cells are burning proteins and fat. They're burning proteins and fat because of these chronic acute phase reactant inflammation markers. Okay. So that's why that's not the right answer, and D's more the answer. All right. This right here we pretty much harped on already, but I'm just showing you this process again. Here is the two images, this being hypertrophic, this being that keloid. Once again, face, earlobes, all those areas, African American. Also a big clue, right? Whenever you see African American, there's certain things that should throw in your head, right? Things like sickle cell disease, things like lupus, things like keloids, because you mainly see them in African Americans. Does that mean you can't see it in any other? No, it's just more likely to see it in these age groups or in these ethnicities. All right. Now, for this one here is mainly getting at this process of adaptation, right? Because that's one of the pathological things that we talked about. So these histologic features are found in which of the following conditions? So what's going on here? Essentially, what's going on here is we have isolated shrunken epithelial cells with hyperchromic nuclei, cytoplasmic blebs, and small discrete bodies. What does that tell you? What's going on here in this tissue? Yes, apoptosis. Perfect. And the reason why it's apoptosis is because, once again, you have these nuclei, they're shrinking. When the nuclei shrink and become pyknotic, they become darker. That's what this hyperchromatic means, this hyperchromatic nuclei. The nuclei is getting darker because it's shrinking down before it breaks apart. Okay? Now, the next thing is these blebs. Blebs are very textbook for apoptosis. You never see blebs in necrosis. Okay? Now, you could get thrown off by this shrunken appearance because when we talked about apoptosis, we said that the cells swell. So why are they shrinking here instead of swelling? The reason why is because of this. Initially, they swell. Okay? This is a timeline. So initially, they swell. As they swell, blebs start to bud off. So this is it. And these little blebs here will start to pinch off. And whenever these blebs start to pinch off, the resulting epithelial cell left is smaller or shrunken. That is why it presents that way. It swells, and as the blebs start to bleb off, it starts to shrink or become smaller because you're losing all that plasma membrane. You're losing all that cytoplasm to the blebs. So the original cell ends up becoming shrunken because all these macrophages are going to come on and eat these blebs. So the only thing left will be this shrunken cell. Okay, so that's why it presents that way. They swell. That's very textbook for apoptosis, which is at the very beginning. But towards the time right before they're fully done apoptosing, they're shrunken because of the blebs being eaten up by macrophages. Okay. Now, let's continue. So now, with that being said, it's just asking you which one of these follows that same apoptosis. And that is C, menstruation, because you undergo apoptosis because they have lack of blood supply, which then ends up leading to you shedding off the endometrial lining. Okay. All these other guys do not play along that same mentality. For instance, myocardial infarction, this is necrosis, not apoptosis. Pulmonary tuberculosis, this is more of a granuloma, right? With it being more caseating necrosis, which we'll see. And then cerebral bacterial abscess. Whenever you get an abscess, that means you get neutrophils. And whenever you have neutrophils, when we discussed last time, they rupture and you get liquefactive necrosis. So that's why A is liquefactive. Good. Now, gangrene, there's two different types of gangrene you can get, which I wasn't able to discuss, but I'll do it now. There's two different types of gangrene, dry and wet. Essentially, this is what ends up happening. When you get gangrene, it's essentially dry first. This is due to coagulative necrosis. Usually of the lower extremities, right? Now, whenever you get this necrosis and tissue death, there's no more blood supply to this area, right? So what ends up happening eventually over time is bacteria come in. And when bacteria come in, they then start to break down the tissue and it becomes wet. That's why wet gangrene is a combination of coagulative and liquefactive. You may have ran across that when you were doing your readings or your videos or Anki cards, something along those lines. And this is why, because it gets seeded with bacteria and then becomes liquefactive because the bacteria also are breaking down the tissue now. Okay? So that is essentially how that happens. All right? Good. Okay. Good. So let's keep going. So we talked about that, talked about the gangrene. Let's keep moving on. Here in 5, a 24-year-old, this is a burn patient, right? And he then explains what type of burn he has. You guys haven't gone over this, but there's different degrees of burns. I'll give you a quick run through of that, which kind of ties in a little bit with your MSK, but essentially they're then asking you which of the following is the most likely contributing factor to what you see in this patient. So essentially what you see is tissue blanching. This is what tissue blanching means. When you get tissue blanching, you have a blood vessel and it is pushing out fluid. Okay? This fluid and dilation of the blood vessel brings in more blood. Right? Now, blood is what color? Red. So as a result, the skin overlying it looks red. Okay? This is the same concept on why when you flush, when you look flushed, it's because you're hot, or maybe someone is attractive around you and you're blushing. It's the same concept. Flushing and blushing, same thing. But anyways, so the blood vessel is dilated, more blood's in the tissue, meaning it's more red or appears red. Okay? Now, with that being said, when you push down on this tissue with your finger, what you're essentially doing is this. You are pushing, increasing the pressure inside the tissue, pushing this fluid back into the blood, pushing the blood out of this artery or capillary bed. That's essentially what you're doing. And as a result, the area looks white because you've pushed the blood out of the tissue. Now, when you remove your finger, the blood then flows back in to the tissue. This is what is known as blanching. Okay? So essentially, this is telling you that the blood vessel itself is not compromised. There's no blood leaking out. No blood in the extracellular fluid. Okay? The reason why I'm saying that is because of this. If you have red blood cells located out here, they cannot get pushed back through. Because what has happened, which allows the red blood cells to present there, is it's cut. So blood is flowing out into the tissue and gets caught in the collagen of the extracellular matrix. So that blood doesn't move anywhere. Even when you push pressure on it, it's stuck there. Okay? That is what is known as non-blanching. Okay? So those are two different types. So essentially, when you see this word blanches, you think this is fluid. It's a blood vessel that's dilated more than what it should be. So there's more fluid in that area, but the capillary itself is not ruptured. There's no blood leaking out. It's only fluid. Okay. So which one of these guys deals with that? Histamine. So that's why B is the answer for this one. Okay. Any questions on this? All right. Good. Now, for this one, it's essentially just asking you if you have this person show up and he's having this appendicitis, is this an acute or chronic? It's an acute issue. It's not chronic, right? So that's why this ends up being A. It's very, very straightforward on this one. So I'm not going to harp anymore on that. This one's a little bit more difficult. 7. And the reason why is because you have to be able to understand what's going on here. So essentially, this is asking you what type of necrosis is most likely to be found in this guy's lungs. So when you have different types of necrosis, we know that in the lungs, normally you get what type of infarct? In normal lungs, you get what type of infarct? Coagulative, red infarcts, caseous, fibrinoid, gangrenous. So you get more of a red infarct in the lungs. And the reason why that is because here's the lungs. You get one blood supply from the bronchial arteries. You get one blood supply from the pulmonary circulation. So you get two blood supplies. So if you end up blocking one, you'll still get blood from the other, and it ends up becoming a red infarct. Okay, remember there's different ways you can develop red infarcts. One is if it's two blood supplies to one tissue. Okay, the other is if you end up having reperfusion post-infarction. Okay, that's the second reason you can get a red infarct. Okay, now the last one that can occur is if you block the venous circulation, so you have blood still left in the tissue, which causes an infarct. Those are the three main ways. So whenever it comes to like dual blood supply organs, don't think of blocking the venous is going to cause you to have a red. It's more because you have dual blood supply in that situation. Okay, with organs that have a single blood supply, an artery coming out and a vein leaving, then I would say yes, red infarct, most likely because you block the vein. That's why you have a red infarct. Okay, so with that being said, that's what you most likely see in the lungs. Now, let's continue. Here in this person, we see that he has all these other things. He has gram-negative bacteria posted. And then they say they did an imaging. So it's an infiltrate. You see, and in this image, you see this thing. So essentially what this is an abscess. Yes, perfect. Lung abscesses have neutrophils going to it. Because essentially the only reason why you get abscesses is this, okay? Let me explain. You get bacteria. This is why you get abscesses. When you get bacteria, neutrophils come in because these are the first guys. Always the first guys that show up, neutrophils. When neutrophils show up, they eat up things, they release lysosomal enzymes. Now, if this bacteria cannot be killed by the neutrophils, and they're constantly growing, and you're constantly throwing more and more neutrophils to it, what ends up happening is you end up degrading the tissue around it. All this tissue around it gets degraded by this lysosomal enzyme to the point that you have a pocket. And this pocket gets filled up with pus because of the neutrophils. Remember, when neutrophils die, they become pus. So essentially, it gets filled up with this pus from the neutrophils. And that is essentially why you get abscesses. Okay? So, with that being said, this is liquefactive. Now, there are other guys here. We've talked about liquefactive. You can see here, neutrophils release lysosomal enzymes that degrade the tissue. Digesting or degrading the tissues is a biggie. They degrade the tissue, so then the tissue's gone, so the only thing left is a cavity. Okay? Good. Good, good, good. All right. Any questions on the Socrative?
Boop, boop, boop. Go back to question 1. I know you said the correct answer was P53.
No, BCL2.
Okay, that's what I thought. Okay. I was just making sure. I know you had made reference to P53. Okay, because that's what I
Yeah.
was thinking. It was BCL2. Okay, thanks.
Yes, it is. P53, I was explaining why P53 was not the right answer.
Okay.
Because P53 is essentially part of that process, right? You can, when cells get damaged DNA, P53 is activated, right? But it's not going to cause the cells to have a maintained abnormal population. It's BCL2 that's going to be the big guy because that prevents apoptosis. Okay. Yes. P53, if you damage P53, it would allow you to have rapid cell turnover, which is true, but it wouldn't help maintain the population. The cells would just rapidly die off, but you'd have rapid cell turnover. Yeah, good. All right. So now let's go on to our next thing, which is the questions. Woo! So I just have the answers here now. I'm not going to go over the questions. You've already had the questions. The PowerPoint, you could have, you had answered them and stuff like that. So let's go over the answers. So with this first one, essentially what they're asking you is this. They do a liver biopsy and you see the image and then they ask you, what is the most appropriate way to confirm the likely diagnosis? So this individual that is presenting here is showing these little dots, which are brown. Okay, these are what is known as cytoplasmic inclusions. Now, whenever you think of cytoplasmic inclusions, there's different types of cytoplasmic inclusions. So if I say cytoplasmic inclusions, what type of things does that make you think of? What type of things could it be? What type of things? Think of things that are in the cytoplasm of cells. Yes. So for instance, it could be lipids. Could be fat. That is grouping together, that's making a cytoplasmic inclusion. Right? What's another thing that's inside cells that are stored? Give me another example. It's why you don't have to eat 24/7 in a day. Glycogen. Good. Glycogen is also stored and is a cytoplasmic inclusion. Okay. The other one, which is not so obvious, is iron. Iron is stored inside cells, right? And it's kind of a segue with GI that you guys had in Med 1. The hepatocytes store it, the intestinal cells store it. That is what stores iron. Now, there are other things that can present inside cytoplasm as cytoplasmic inclusions. One other thing is this. So you have the phospholipid bilayer. Now, when we discussed last class and lecture, you get various free radicals. Whenever you get decreased oxygen, right? Whenever you get decreased oxygen, free radicals start to develop. Now, these free radicals damage various things. Okay? For instance, it goes to the phospholipid bilayer and causes it to become peroxidized. Okay? It peroxidizes the phospholipid bilayer, damaging the bilayer of the cell. It also goes to the DNA, leading to oxidation issues. It oxidizes the DNA, which damages the DNA. Okay? The other thing it ends up doing is the proteins present. It will go and attack them and oxidize them as well. These are the three big things that free radicals do. They deal with peroxidation of phospholipids, oxidation damage of the DNA, as well as oxidation damage of proteins. Make sure you remember this because you will see questions on this when it comes to pathology. Now, with that being said, the only thing that's different is that with the phospholipid bilayer and how it's peroxidized, this presents as an inclusion. This inclusion is known as little droplets that are brown. And these little brown lipo droplets are called lipofuscin. You may have ran across that word when you were studying. Okay, lipofuscin is literally just phospholipids that have been peroxidized and they become locked in these inclusions because these are non-degradable. They're non-degradable. Okay, you can't degrade these guys in the lysosomes, so they accumulate and they just stay there as these brown pigments. Now, this is normal. This is what is known as aging. If you were to biopsy my tissues, you would see lipofuscin in it. Okay, just because I'm older versus my daughter, who's 4, she's not going to have no lipofuscin in her tissues. Okay, now, with that being said, what do you think would prevent the formation of lipofuscin? What do you think prevents the formation of lipofuscin? Think about it. You got these free radicals. Free radicals are the guys that's causing the damage. Do you know of any way to remove free radicals? Any way to remove free radicals? Um, Yeah, superoxide dismutase can change superoxide into hydrogen peroxide. Yes, you're right. But these free radicals are more hydroxyl free radicals. So we're thinking of, yes, we're thinking of things like vitamin C. We're thinking of things known as antioxidants. This is why they say make sure you have a high amount of antioxidants in your body, because not only is it helping you here with preventing these inclusions from forming, causing oxidative stress issues, but also it helps with a variety of other things, atherosclerosis, so many other things. And you'll go through that when you get there. But antioxidants are very important. So make sure you keep up on your antioxidants, your vitamins, ACE, okay, as well as various things like glutathione and stuff like that. All right, good. So any questions on any of that? Still recording? Yes. Okay, good. So with that being said, you see these brown pigments, you now have to depict what type of inclusion this is. Is it lipids with fat? Or is it aging with lipofuscin? And the last one is what is known as amyloid. Now, iron and lipofuscin both present brown. Okay? Fat, as in lipids, and glycogen both present clear. Amyloid, you have to use a specific dye for, but will turn it green. These are the different presentations and as well as inclusions. So for iron and lipofuscin, they both present brown. So that means you have to have some kind of stain for being able to differentiate if it's brown. This could be fat peroxidized or could be iron. How do I differentiate between the two of them? Is this thing known as Prussian blue. Prussian blue helps you find out if it's iron. Okay? So what will end up happening with Prussian blue, it will turn the iron blue. But lipofuscin, no change. That's how you could depict what this brown inclusion is. Okay? Now, let's think of lipids versus glycogen. You guys know of something already. What can help you differentiate glycogen from lipids? What stain? You guys went over this when you did glycogen storage diseases. In Med 1. Pass. Perfect. Periodic acid sift stain. This will stain glycogen, but not lipids. Okay. Now, they add a new one here with pathology, which is Sudan oil. Sudan oil will stain lipids, but not glycogen. Okay. So they could either do a Sudan stain or a pass stain to help differentiate between lipids and glycogen. Okay. Any questions on that? No? Okay, good. So with that being the case, that's why this answer ends up being D. Because you see a brown pigment, you need to use Prussian blue to see if it stains blue, then it's iron. If it doesn't stain, it is what? If it does not stain blue, it is lipofusion. Yeah. Okay, good. Because you're saying that it's brown. So you first have to see what the color of the inclusion is. You can see it, it's brown. So it can either be iron or lipofusion. If it's clear, it can be what? If it's clear inclusions, like you see these cells like this, and then you just have a nuclei chilling out here like this, and the rest of this is just clear. It could be lipids or could be glycogen. Lipids or glycogen. Okay. You do a pass stain, you stain it with pass, positive glycogen. You do a pseudon stain, positive lipids. Okay. Good. Now, there are other things pertaining to inclusions, what is known as calcifications. Okay. So calcifications is literally just the buildup of calcium. So let me throw you guys back to Med 1 real quick. If you guys remember, you have calcium and phosphate. These guys combine together and they precipitate out as calcium phosphate, right? These are crystals. Good. This is literally just the Med 1 rehash of bone. Now, calcium binding with phosphates to become calcium phosphates is inhibited by a factor which is known as diphosphate or pyrophosphate, you may have heard it as. This inhibits the production of calcium phosphate to the crystallized form. Now, this pyrophosphate is created by your cells. This is why your cells, under normal physiological cases, do not calcify. Your cells run around, never getting calcified by calcium. But only in bone do you undergo calcification. Because in bone, your things such as alkaline phosphatase does what? What does phosphatase do? Phosphatases remove phosphates. So this is released by osteoblasts. Phosphatase remove phosphate. So if you remove a phosphate from pyrophosphate, you no longer are inhibiting the process and calcium can crystallize on the bone, changing osteoid into bone. Okay? Now, with that being said, that's what's going on. That's this whole process. So if you damage cells now outside of the bone, let's say the cells here are damaged and they're gone. That means pyrophosphate goes down. So what do you think is happening now in that tissue? Since the tissue is damaged, you're no longer pumping out pyrophosphates. Calcium and phosphate is now able to crystallize at that location, and it will become calcified. Okay? Does that make sense? Okay, good. Now, the last way it can happen is this. Your cells produce pyrophosphate, right? However, if you have too much calcium, too much phosphates, it can overwhelm pyrophosphate to the point that you still calcify. This is the second way you can calcify tissues. Okay? This is the big thing to remember. Cells release pyrophosphate that blocks this process. So if you damage cells, you get calcification. If you have too much calcium and phosphate, you get calcifications. Now, these are known as dystrophic versus metastatic. Okay? Dystrophic is whenever you get diseased or damaged tissue. You now know why. Because you don't have pyrophosphate, so now calcium and phosphates can merge together and calcify the tissue. Okay? That is what's happening. Now, the other one is metastatic calcification. Now, if you remember, I said nothing was the issue with the tissue. The issue was too much calcium, too much phosphate. And because of that, you calcify it. That's why you have normal tissue, which then leads to calcification. Now, here's this big thing. High pH favors this. So, with that being said, that's why you have metastatic calcification in three main locations. Three. One is lungs. One is kidneys. One is GI with the stomach. Why? Can you tell me why in the lungs? This is physiology now. Because you understand this one already. I've gone through this and you understand what's going on here. Damage to tissue cells, bam, calcification. What's going on in the lungs that would cause you to have metastatic calcification? Here's my lungs. What's going on? What happens when red blood cells go to the lungs? What happens? They drop off CO2. Yes. Now, when you lose CO2 and they pick up oxygen, yes, you're right, they pick up oxygen. Now, when you lose CO2, what happens to the acidity of the blood? It increases. You get a localized, the big word, localized alkalosis. That localized alkalosis is what allows you to take that calcium and phosphate to form calcium phosphate. resulting in metastatic calcifications. Now, the kidneys. What happens when you are metabolically acidotic? Or in general physiology, what happens at the kidneys? Your kidneys is responsible for absorbing bicarb. That's what your kidneys do. They absorb a crap ton of bicarb. That's their responsibility, right? You pee out bicarb, it absorbs bicarb, and it makes new bicarb to compensate for your fixed acids. This is a run back to renal. Okay. Now, when you have all this extra bicarb coming in, you get a localized alkalosis. Same thing. Last one, stomach. What happens in the stomach, particularly when you push out acids from the parietal cells? Yes, remember, your cells push acids out into the lumen, pushing bicarbs into the blood. This is known as what? This is known as the alkaline tide. This alkaline tide is the reason why, once again, metastatic calcifications. That's why you have them in these three areas. You don't get them everywhere because you do not have localized alkalosis everywhere. You have it at these specific locations. Now, does that mean that you won't ever see calcifications anywhere else if it's metastatic calcification? No, you could see it in other places, but it's just not as likely. You're going to see it more likely in these areas: the lungs, the kidneys, as well as the stomach. Okay? Any questions on that? Good. Now, we've talked about that. We've talked about the etiologies, injury or necrosis. This is due to high levels of hypercalcemia. Lipofuscin, we talked about. This is the wear and tear pigment due to phospholipids complex. This is that aspect of peroxidation of lipids. Okay, here you get lipid peroxidation. Now, you're going to see this lipofuscin in all the organs. Just think of it like that, all the organs. But where you're more likely to see it, things like the heart. The reason why you're going to see it more in the heart is because they love to throw you a picture of the heart and ask you, is this due to iron deposition? Is this heart? Did he have a heart failure due to iron depositing in the heart? Was this because of, normal wear and tear? That's why they love it. Because there are pathologies that you'll learn later, such as hemochromatosis, which is this iron being deposited all throughout the body, especially in the heart, that they love to tie in. Okay. So if you ever see lipofuscin, more likely the image that they're going to show you is a heart or the liver. The liver is another big one that they'll show you. Because hemochromatosis also attacks the liver. But amyloid is the last one. This is just abnormal proteins. And as a result, you do a certain type of stain, which is known as apple green birefringence, with a Congo red stain. Okay. And it looks apple green. Now, that's it. Let's take a 4-minute break, come back together, and we'll push through some more questions. Okay. I hope I'm not going too fast. No. Okay, good. All right, guys. Let's meet back here at 6. You want to do 6:15 or 6:14? I feel like 6:15 is better. It's like a whole number. It's like interval of 5. 14 is kind of weird. Okay, 6:15. All right, guys. See you in a bit. All right, let's continue. So, so if we see dystrophic calcification, what are we thinking? If you see dystrophic calcification, what are you thinking? If you see dystrophic calcification, you're thinking, uh-oh. If we end up losing energy, oh